Good afternoon, everyone. Welcome to our next PQS webinar. This one is on the DOAC optimization target. I'm going to kick off in a second. Kirsty's just struggling to get on, but I'll start going through the presentation. So just a reminder, just as an introduction, if I haven't met you before, my name's Janice. I'm one of the medicines and optimization pharmacists in the ICB team. So just a few housekeeping rules. If we can just try and keep cameras switched off and microphones on mute. Any questions that you have, please pop in the chat, or there will be time to discuss for questions as well. So the chat will be looked at by the MedSop team as well. We are recording this webinar as well, so we will post the recording and the slides onto the SharePoint page after the session. So I'm just going to quickly go through the introduction to the PQS and the DOAC target in specific, and then Kirsty is one of the is the lead anticoagulation pharmacist at Buckinghamshire Healthcare Trust in the DOAC clinic. So she'll be going through the clinical elements of this, and like I said, we've got time for questions as well. So hopefully you've already come across the PQS, but if you're new to the scheme and you haven't managed to look at the PQS document or aren't familiar with it, it's our prescribing quality scheme within primary care. So it's an optional scheme open to all practices within BOB. And we're looking at improving the quality, safety and cost effectiveness of prescribing within the BOB primary care footprint. So the scheme is already launched from beginning of April, and it will run through to the end of March next year. So there are 5 clinical targets in the scheme, and there are some requirements around script switch, and the information on that is in the participation and agreement forms that your practice managers and prescribing leads, all the information will have been sent to them already, and the value of the PQS. If for some reason they haven't received that information, please do email into our team inbox, and we can make sure we can send that out and update any contact details if we need to. Each target is worth 20 points, and you can choose to do all of the targets or some of the targets. So like I mentioned before, there is a criteria for participation, and that has been updated for this year. So please do have a look at that. If you've got any questions at all, please do get in touch with the team. And if you're choosing to participate in the scheme, which we hope most of the practices will, please sign the agreement form. And if you return that to our team inbox by the end of May, please. So just a reminder on the targets and the webinars that we've got for that. So we've already held our SABA, our oral nutritional supplement, our overprescribing webinars, and then we've also held a separate webinar on script switch and the PQS requirements. All the recordings for those are already on our BOB SharePoint page with the slides as well. After this webinar, there is one more target that we'll have a webinar for, and that's falls prevention in patients aged 65 and over on 10 or more medicines. So we'll let you know when that one's scheduled to run. All our resources are on the SharePoint page. So that's information regarding the overarching document with the information, the participation agreement forms, clinical searches that you'll need to run for those, all the data collection spreadsheets with information, and like I mentioned, the webinars as well. So for your practice and for your PCNs, you do have a team member within the MedSop team who is your kind of key contact for that. So they will be in touch throughout the year to just check in to see how you're getting on. And if you've got any questions, please do get in touch with the team or with your link member of the team here. So just a brief background on the target. So we've made a change this year. So the last few years for cardiovascular, we've done lipid optimization, and we've done an amazing job on that, which hopefully you will have seen the report that we've come out with after each year to show the improvement. We're just in the middle of closing the scheme that's just closed. So we'll put information on the achievements and the impact that that you have achieved through that. That we're making a change to in cardiovascular to DOAC optimization and atrial fibrillation. So I don't think I need to go through all of this, but there are some really kind of key parts. It's definitely something that it's there's more and more people with atrial fibrillation, and the lifetime risk is quite high now, and there are a lot of adverse events and impact, other clinical impact as well of the condition. So in terms of strokes, all strokes, about 20% are thought to be atrial fibrillation related, and they are so it's a 5-time higher risk if you've got AF as a condition in terms of stroke risk. 30% of those patients could go on to have a second stroke as well. And having worked at the anticoagulation clinic and seen the patients, we know that the strokes can be more severe as well, and it increases their risk of other conditions like heart failure and cardiovascular mortality. So we know anticoagulation reduces the risk of stroke by up to 2/3. So DOAC is now the preferred one to be an anticoagulation over warfarin to be initiated on from the NICE guidance. So there's lots of things to consider when you're looking at DOACs, what dose, and although there's less monitoring than warfarin, there is still ongoing monitoring that should be carried out, and obviously any required dose adjustments should be made. Why we're looking at underdosing, although I think we tend to, I think people worry about overdosing and bleeds, but actually an underdose could be just as important, because obviously if we haven't got maximum stroke protection, they're already at high risk, and if they're not on the right dose, we could be preventing a life or an event happening. And obviously the financial and social impact of a stroke is obviously very significant depending on the severity as well. So how we're looking at the data collection for this, we've got templates that for the individual DOACs. So what we're asking to do in this target is from the searches that we've got for you, it should pick up patients who've been coded with non-valvular atrial fibrillation and who are currently on a DOAC. But each one of the DOACs, it's based on ARDEN searches that are already there. It will pull out the patients where it looks like from their latest bloods and clinical parameters that they potentially might not be on the right dose. So there's background information, there's instructions on how to run the search and things you might want to consider when doing the reviews as well. There are separate tabs for each DOAC, so although it looks like a very big spreadsheet, there isn't an easy way to put them all on onto one tab. So as I mentioned, the first kind of part to it, the main part is looking at patients who are already on a DOAC with non-valvular atrial fibrillation and who may need their dose adjusting. So these are the kind of parameters that have been pulled out of where you're looking at what you would use to estimate what dose they should be on. The edoxaban, there is 2 bits to it. So as well as underdosing, in terms of where it should be increased, there is a cohort of patients where probably not as many, but there are still some patients who have got actually really good renal function, and if their creatinine clearance is above 100, then edoxaban might not be the best choice for them, because actually they might be clearing too much of that. So that is another bit that will come out in the search for edoxaban, and there are kind of separate bits to it. So you'll see when you pull that across. So I've just screenshotted a bit of what the data collection template will look at. So the yellow bit, so it will also, from the auto report, you should be able to just pull and copy across into the spreadsheet. So that's kind of grey section, all of this section. But as a reminder, when you're sending them back into us, just to remove the yellow column, so that's the EMIS number and age. So for anything that you need to have a look at, the section where you want to put information that you've gathered, that's kind of the orange section. So put in what you need to do the review, and then what the bit when we're looking at when you've returned it to us, that the MedSop team will review is the actions, I guess, we're hoping to see from you. So actually, have you made an adjustment on the dose after you've checked they've got up-to-date bloods and their patient and other parameters of the patient? Yes or no? And if it hasn't been adjusted, a reason why it hasn't. So they might actually meet the criteria for low dose. So it would be good to know that. But this is a bit that we'd ask for it to be really clear on, because when we're reviewing the evidence, this is the bit that we'll focus on, and not the other sections on there. So there is a second bit to it. So this will pull just from that initial part 1. So there has been a change in the monitoring recommendations for certain patients. And I think that kind of came out last year, but it wasn't really kind of released anywhere. But I think everything's catching up now. So I think it was on the NICE CKS last year, but I know Ardens have in the last couple of months updated their searches on there, and actually SPS have now also updated their DOAC monitoring page as well to align, and it's based on the European Society guidelines in terms of monitoring. So the patients with creatinine clearance 35 to 44 mils per minute, or in those over 75 years, or those who are frail, where they haven't got a recent bloods within the last 4 months. It used to be 6 months, but it's come down to kind of 4 months. So that's what this section will pull in the search. So again, it's the same kind of information. Obviously, it's slightly different baseline information that will pull out from the auto report, which is why there's a separate bit to separate tab for this. And again, orange section is the section for you to put in what you need to do the review. And again, the green section is the bit when it comes to the evidence review panel here back at the ICB that we're interested in. So have you recalculated, if needed, their renal function using the Cockcroft and Galt? Have all their bloods that need to be done, are they up to date, and the date of completion? So we're just looking for that to be updated and done on there. So hopefully Kirsty is online now.
I am. Updates all done.
So I will pass over to Kirsty now.
Hello to everybody. I'm Kirsty Scott. I'm the lead DOAC pharmacist at Buckinghamshire Healthcare. We're based in High Wycombe, but we cover the whole of Bucks. We do some warfarin, so we can answer some questions on those, but basically we are sort of lead with the DOACs. Can I have the next slide, please, Janice? Thank you. So what I'm going to cover today is predominantly dosing, because that's what we're looking at here. I have got a little bit on interactions, more for interest. I'm not going to cover it in detail. And if there's time at the end and you've got any other questions on the DOACs that maybe isn't quite related directly to this, if there's time, I'm more than happy to try and answer them. I've put a couple of case studies in there. I promise they're not horrible. They're just really to get you thinking about the dosing, and we'll go through those together. Thank you. So with the DOACs, when we're initiating, we've got to think about how we're going to initiate a DOAC. Are we switching from warfarin? Is it just is it new anticoagulation? Predominantly, obviously, today I'm going to focus on AF, but we do need to think about the indication. It's not the same dosing for acute VTE It's not the same dosing for long-term prevention of VTE as it is for AF. Some patients will have both indications. I'm going to go through the criteria for dose reduction in each drug. It's sometimes when these dose reductions come about, that's when we see some of the mistakes coming through, and it's across both primary and secondary care. We see plenty of it in hospital with the wrong dose because somebody thinks they know, and I'll go through some of those mistakes that we do see. Renal dose adjustments. How do you calculate your renal function? All the trials were done using Cockcroft and Galt equation, so that is what we should be using. That's how the doses have been calculated based on the creatinine clearance using Cockcroft and Galt. EGFR does not give us the same result, therefore the borders for the dose changes are not the same. So that is something that we do sometimes come across, so just remember that. Janice has already mentioned a little bit about the ongoing management of each of the oral anticoagulation options. It's not huge with the DOACs, but there is still some monitoring required, and we do have some patients who think, oh, no monitoring whatsoever, I can have my tablets and I never have to go and see anyone again. And then we also sometimes need to switch between agents. Now that can be a warfarin to a DOAC switch. It's sometimes a DOAC back to warfarin switch, or it can be between the two different DOACs if we've got patients that don't tolerate one, but they might tolerate another. Thank you. So Apixaban, now available as generic. It's certainly for us in secondary care, I think probably in primary care too, it's the most cost-effective DOAC. The standard dose that you would see in AF is 5 milligrams twice a day. Doesn't have to be actually 12 hours apart, but we do encourage patients to take it as close to that as possible. The emphasis we put on is that it's morning and evening. We do occasionally get patients taking their Apixaban with their frusemide dosing, so they'll take it morning and lunchtime. So, not strictly dose related, but it is sort of how they're spacing their dose. So with Apixaban, the renal dose adjustment, it comes down to half dose at 2.5 milligrams twice a day. Patients need to fulfill 2 of 3 criteria. This is sometimes where we see mistakes creeping in. So age over 80 years, that's quite a large number of patients within the cohort that we're looking at. But the body weight must also be less than 60 kilograms or their serum creatinine greater than 133. It's not uncommon for us to see patients on a reduced dose just because they're over 80, but that alone is not sufficient to reduce the dose. Sometimes we notice that the 133 micromoles of creatinine, sometimes that gets overlooked. It's less common for us to see that, but it is something to consider. Alternatively, if the overall creatinine clearance, which is calculated with Cockcroft and Galt, if that is between 15 and 29, so basically if it's less than 30, that alone is a criteria for a dose reduction with the Apixaban. Thank you, Janice. So, as I say, check that the patient, when you're going through your list, check your patient does fulfill 2 out of the 3 criteria for that dose reduction. And that's if the creatinine clearance is above 30. I say reducing for age alone, it's a very common error. I think that's probably, we don't have specific statistics on it, but I think it's probably the most common error in dosing that we see, particularly with the Apixaban. Sometimes we have patients borderline dose reduction. What are you going to do if a patient's creatinine clearance is around 30? Do you reduce the dose or don't you reduce the dose? You may think, well, I'll play it safe and I'll reduce the dose, but actually if you've got a patient who's very high risk of stroke, if they've got a high CHA2DS2-VASc score, then actually you're putting them probably at greater risk by reducing the dose than if you give them the full dose. Do you just go with, if they're, do we just leave them on the same dose and see what's happening? What we actually do in the clinic is we will look at the trend the creatinine, of the serum creatinine. If it's fairly stable, you might want to make a call based on the stroke risk. If it's up and down, yeah, and spiking, you're going to have a bit more of a challenge. Sometimes the solution is to pick an alternative DOAC. We find that sometimes alleviates the, what's it today? Is it 29 today or is it 31? We do go for that as an option, and when we pick that from the DOAC clinic, we hope that it makes your lives easier in general. Look at the stability of the patient weight. Are they losing weight? Are they likely to gain weight? Is it fluid that's causing that's giving them the weight? There's no adjustment for patients that are carrying excess fluid. It's perhaps a clinical judgment, but it is something to consider. But if they're rapidly losing weight, again, you might go for the lower dose if they're over 80. One thing that we really don't encourage is reducing the dose for suspected side effects. If a patient is not tolerating the DOAC, then they need a different DOAC. So one of the risks of doing that is, well, we'll halve the dose because then they won't get side effects because they won't have as much of the anticoagulant on board. If you do that, they're still at risk of side effects, believe it or not. Even though they're subtherapeutic, they're not going to get the benefit, they're not going to get the stroke reduction, but they could possibly still have some bleeding. So we tend to say, well, you are then looking at changing to a different DOAC. Once we've been through all the DOACs and, you know, if warfarin is not suitable, then we maybe have to think again. But certainly in the first instance, no dose reductions for side effects for apixaban. Thank you, Janice. Moving on to rivaroxaban, probably actually one of the simplest dosing regimens of all the DOACs, certainly for AF. 20 milligrams once a day, reduced if the creatinine clearance is less than 50 to 15 milligrams once a day. Yeah, nice and easy. The thing to remember is it does need to be taken with food, and that does strongly affect its bioavailability. So it's about 2/3 as effective if patients take it without food than it is with food. So just something to bear in mind in counselling, but that doesn't affect the dosing. Thank you, Janice. So yeah, as I say, only reason to adjust the dose is creatinine clearance. You have the same with the apixaban. You might get borderline serum creatinine clearances. So if you've got an apixaban that you're not sure, is it, do we give 2.5 or 5? Well, rivaroxaban is perhaps an option. The dose reduction occurs at 50. So if somebody's got a creatinine clearance around about the 30, you know you'd be using the lower dose of rivaroxaban, and it is then clear cut. They're not going to change that much. On the other hand, if you've got somebody who's got creatinine clearance around about the 50, apixaban is perhaps an option you might consider, just making it easier for the patient that they're not going to have to keep changing doses or DOAC. So again, that's something that we look at here. And as with apixaban, please don't reduce the dose for suspected side effects. Consider another option. Sometimes with these anti-10As, with apixaban, rivaroxaban, and edoxaban, sometimes what we see is just an isolated drug that a patient doesn't tolerate. So you might get side effects with the rivaroxaban, but not with apixaban. It's always worth trying another one. Sometimes, however, we see a class effect. If a patient has identical side effects on 2 out of the 3 DOACs of the anti-10As, we often don't try the third. We do occasionally, but often if they've had the same side effects with 2 of them, they'll often have them with the third because it's a class effect. But as I say, we don't reduce the dose for suspected side effects. We go for other options. Thank you, Janice. Edoxaban. So we don't see so much underdosing, I don't think, with edoxaban. 60 milligrams once a day, nice and easy, doesn't have to be taken with food. It's not top of our list of DOACs now. Rivaroxaban for a once a day would be our preference. But if you have issues with a patient taking it with food or certain other issues, then we might well look at edoxaban. The renal dose adjustment is down to 30 milligrams, so that's half dose. Like rivaroxaban, the reduction occurs below 50 mils per minute. We also have thrown in there if they've got a body weight of less than 60 kilos. And again, you know, that's a standalone criteria for a dose reduction. It's not like a Pixaban where you need 2 out of 3. There are also 1 or 2 medications, some of them acute, some of them more chronic, that you would need to dose adjust for. It's probably easier in most cases to pick a different DOAC than dose adjust for some of these, but I've put it in there so that you've got the information. Thank you, Janice. So once again, quite repetitive through this bit, borderline dose reduction. Again, creatinine clearance, a bit like the rivaroxaban. If it's around about the 50 mils per minute, you might want to switch to a Pixaban. You might want to consider something else just to make life easier for both you and the patient. What we don't have with the other 2 anti-10As, but we do have with the doxaban, is the impact of high creatinine clearance. If a patient has a very high creatinine clearance, so basically if it's over 100, we tend to avoid it. It is quite highly renally cleared, and there was some suggestion that a patient may be subtherapeutic if they have a high creatinine clearance by the time they get to the end of a 24-hour period. So we tend to avoid it if the creatinine clearance is above about 90 for initiation. If your patient comes to you and their creatinine clearance is 95, they're well established on edoxaban, there's no reason to change, then they don't need to be switched. It's once it really gets above 100 that the problem occurs. So you have got a little bit of leeway. It's worth bearing in mind though that creatinine clearance, when we look at that, it is literally what that patient's clearance was at that particular moment when that blood test was done. So it is a tiny snapshot. So the reason we don't tend to go for it for initiation in the DOAC clinic above about 90 is because we know that, well, if their creatinine clearance was 95 today, maybe next week it'll be 100. It might not, but so we tend to just give ourselves a little bit of room for that creatinine clearance to change. But it certainly, if your patient has got a creatinine clearance over 100, if that's picked up, then they actually need to switch to a different DOAC. It's not about dosing there. And again, looking at the stability of the patient weight, if their weight is around about the 60, maybe you want to pick rivaroxaban. Maybe, maybe they're on board, you've got a lot of fluid on board, you know that it's going to drop, or maybe they're generally losing weight or gaining weight. So worth looking at. And again, please don't reduce the dose for suspected side effects for the same reasons as with the others. Thank you, Janice. So we see quite a lot less of this one, dabigatran. The original DOAC, but certainly not prescribed in the quantities that it used to be. The standard dose of this for AF is 150 milligrams twice a day. There are slightly more dose adjustments for this. Again, creatinine clearance less than 50. What you do need to remember is that with dabigatran, it is contraindicated if the creatinine clearance drops below 30. So all of the others you can use. The Pixaban's the preference, but the other 2 you can use with caution. But dabigatran is a definite no, and that's because it's 80% renally cleared. So if a patient is over 80, then the dose is reduced. So based on age alone with dabigatran, their dose can be reduced. Again, taking some medications, particular verapamil, they would just ordinarily have a dose of 110 milligrams. We then get into a slightly grayer area. If a patient is at high risk of bleeds, or if they're over 75 and considered at a moderate risk of bleed, and these are all taken from the SPCs of the drugs. Some other patients, if they have an increased risk of bleeding for varying reasons, and patients with gastritis and other GI related disorders, they can also all have a dose reduction. So with dabigatran, as you'll see on the next slide, we can actually modify the dose because of side effects that a patient's having. So it does have some some place in therapy. It's also good in patients that don't tolerate any of the anti-10As. Thank you, Janice. So again, we look at the borderline for dose reduction with regards to creatinine clearance and the serum creatinine. A patient's age is the patient's age, but if they're sort of sitting, as soon as they hit 80, they would have a reduced dose of dabigatran. With the creatinine clearance with dabigatran, we tend not to initiate if the creatinine clearance is in the low 30s unless we have no other option, and that's because quite often it fairly rapidly drops to below 30, and then we're in an area where we shouldn't be using it at all. And we do occasionally get patients that if they've been on it and it's not been picked up that their creatinine clearance has dropped below 30, it can accumulate and then cause coagulopathies and serious bruising and bleeding. The other considerations, so is that aside from the higher contraindication from creatinine clearance, the age. Sometimes it's quite nice to have one that the dose is reduced on age alone. I can only assume that when dabigatran came out, they assumed that if you were 80, your renal function wasn't as good, therefore you needed a dose reduction. And as I started to say on the previous slide, for dabigatran, you can consider a dose reduction in a patient with side effects. So maybe if a patient's got hematuria, particularly if they're over 75, we can reduce the dose within the license. So wherever possible, we like to try and use medications within a product license. Not always, sometimes it's an off-label use, but with the dabigatran within license, we can reduce the dose. So due to side effects. Patients with reflux-related disorders, it's an interesting one because dabigatran itself causes quite a lot of reflux. So again, you're really reducing the dose probably due to the side effects. But obviously they are still at risk of some side effects. So it doesn't always get us out of the hole we're in. Sometimes we do have to switch drug. Thank you, Janice. So before I go on to the dual indications, does anyone, I know things have been popping up in the chat. Do you want me to go through any of those questions now?
It's up to you, Kirsty, but do you want me to go through a couple of them?
Yeah, we can go through a couple now.
I think the first one of the ones was, so if they're over 80 years old and weight less than 60, and this is for Optimisation, so over 80 and weight less than 60.
So I couldn't catch all of that. You disappeared. Sorry. Over 80.
Over 80 and weight less than 60 kilos. So this is for Optimisation.
Yeah. So for AF, we would reduce the dose.
Okay. I can't remember if you were going to cover a bit on weight and above 120 kilos. So those.
I haven't got any slides on it. I can go through that at the end because it doesn't really affect dose, but I can go through what we currently do at the end. Yeah.
Okay. I think some of the other ones we might leave a bit later because you're going through monitoring as well later, aren't you?
Yes, I think so.
Yes, I'll go monitoring. Which DOAC between rivaroxaban and edoxaban is preferred if they've got a history of GI bleed, but they'd like to have a once a day DOAC?
It depends on the dose. So from recollection, edoxaban 30 is better than rivaroxaban 15. Apixaban would be our preferred. So we might try and persuade them to go for twice a day. Once we get onto the once a day, edoxaban maybe slightly, but there's not significant enough in it that we make a difference in what we pick. We would still, we might do if we can dose reduce to, if they're less than 60 kilos and they've got a GI history, we might pick edoxaban because we can dose reduce, but we might not be able to dose reduce with the rivaroxaban. But we would look at other factors as well. don't know whether that really answers the question for whoever asked it, but
because I guess it's the it's very individual. There's no black and white answer, and it depends on other factors, which makes it can make it a little bit more complicated sometimes. So it's really that kind of individual patient review as well. So someone, Natalia, has asked about we're advised to use edoxaban as first line, and then obviously is this no longer the case? So I can go through this. So that was an NHS England commissioning recommendation, which came out as the most, when they did a procurement review, that was the most cost effective at that time. And obviously, as you all remember, they did put it into the IIF as well at the time to encourage the edoxaban kind of prescribe where it was clinically relevant for patients to be used as for patients to be put on edoxaban as first line. That has now changed. So that was kind of last year, and it was September, the latest update. So now generic apixaban or generic rivaroxaban are the best value ones, which are kind of recommended if things are where all kind of things are clinical considerations are equal, and you've got to pick either once daily or twice daily, and there's no particular reason why, say, a patient has to be on edoxaban. We would expect that either generic apixaban or generic rivaroxaban are used. And I keep on saying generic because obviously they have come off patent. So if you know, Eliquis is much more expensive than generic, and we do have to factor that in. So if we can obviously prescribe generically, we should do. I guess for us within Bob, not just within Bucks, we've never had official first lines in terms of DOACs because we've always gone with the kind of clinical thinking of it's got to be the right DOAC for that particular patient. And I know, Kirsty, like, you know, you've seen patients who've been through every single DOAC and don't tolerate a single one, or there's only one that they'll tolerate or kind of do best on. So it's whichever kind of DOAC is right for that patient. But obviously, if everything's equal, then generic apixaban or generic rivaroxaban would be the preferred ones because they are best value. And as I'm sure you're all aware, there is a lot of financial kind of scrutiny within the NHS at the moment. So we have got a position statement on this, which are on all the formularies. So if you haven't seen that, do kind of look at that. There's one about what if you can't get an up-to-date body weight? Patients with bedbound.
It's a challenge. It's a regular challenge that we have trying to get people with up-to-date body weights. Ultimately, we have to use the most recent that we can possibly get. I don't think we would have it as a contraindication unless we thought that patient's weight was contraindicating them. Yeah, some people are better at estimating than others, as we well know. We've had patients estimated at 80 kilos and they've been 130. So, you know, that's on the hospital board. But yeah, as up to date as possible. And sometimes, you know, if you're not able to get a weight and you've got one that's a year or two old, you can look at the patient and see that they haven't lost a lot of weight, that they are about the same. Or you pick one that you think that the weight is not going to be quite so critical in it. It will always be there in the calculation for renal function and for creatinine clearance. But at the end of the day, that is an estimation. So you know, we have to look at the situation and again take it as an individual situation and see whether we can work with something, or if we think everything's going to be borderline, what do we do? You know, would they cope with warfarin? Is that actually the safest option? So yeah, we have various options, but we take each one as an individual.
I think that well, there definitely are more questions. Not I think there are more questions, but I think some of that you'll cover with your kind of next slides. But I think because there's so many questions, what we might do, Kirsty, if it's okay with you, is if we put it into an FAQ document for afterwards as well.
Yep.
And if we don't get through them all,
yeah, that's fine.
Put it together. But do you want me to? I'll go on to your next slide.
Yeah, that would be great. So I've just done a little bit on the dual indications. So by that, I mean, if we've got a patient who's got both AF and DVT, PE, how do we decide how to dose? So this is somewhere that can cause some confusion. You know, and certainly even in training new staff into the DOAC clinic, it's probably the trickiest area that we go through. So critical things here are a date of the DVT or the PE. Was it within the last 6 months? If it was in the last 6 months, then whatever we do, we must make sure we are treating them with a treatment dose. Otherwise, their clot will go untreated. If it's over 6 months, then we're probably on to prevention of long-term VTE. Obviously, you know, some patients stop therapy at 6 months. They just need a 6-month course or a 3-month course for DVT. And that causes a bit less confusion. Once we go beyond the 6 months, then generally they are on a dose that's for long-term prevention. We then look at the dose that they would be on for AF. So, you know, do they need any dose reductions for renal function? For VTE, we don't tend to dose reduce for renal function with apixaban and rivaroxaban, and they are the most likely ones that you will see for dual indications. So we need to consider any renal dose reductions or any of the apixaban dose reductions or weight dose reductions that would be in play for AF. We then, you know, we'll have a look at the other factors that affect what we do. High BMI, and I'll go on to that. I can cover that in more detail at the end because I haven't got anything specific on it. Is there a high risk of recurrence? Is a DOAC appropriate? Some of these patients with VTE, actually, they shouldn't be on a DOAC. They shouldn't ever have been switched to DOAC because if they've had clots whilst on anticoagulation, they should be on warfarin with a higher range of 3 to 4. And a DOAC won't cover a range of 3 to 4. They are equivalent, whilst we don't do INRs, they are equivalent to warfarin at a range of 2 to 3. So it might be that suddenly your patient's not actually appropriate for that DOAC for their AF because of the type of VTE they had. Thank you, Janice. So this might cause some confusion, this slide. I did try it out on Janice, and I think it made sense, but I'll try and explain it through to you. So if you've got a patient that's on their DOAC for AF, then all right, my laptop is just can you still hear me, Janice?
Yes.
Yeah, it's all right. It's fine. The laptop's just done something. So stroke prevention in AF, apixaban, if they're on a 5 milligram dose, don't need any dose reduction. They have, you're wanting to start them on that. If they've had an acute VTE and they've been they're being in the treatment phase, then they would be on 5 milligrams twice a day also for their VTE. Now that's nice and easy. That means that certainly in the short term, they would be on 5 milligrams twice a day of apixaban for both AF and their acute VTE. If they need to stay on apixaban because that DVT or that PE that they had was unprovoked, so they've got to stay on long-term prevention, what dose are you then going to have them on continually? Well, we always pick the higher dose that's required for whichever indication. So in this instance, we would keep them on the 5 milligrams twice a day. We wouldn't dose reduce after 6 months, as we would ordinarily do in somebody who stays on long-term apixaban for a PE. But we want to make sure that we are giving adequate stroke prevention. So that's why we're not dose reducing there. If I then take apixaban for AF and somebody's on needing the 2.5 milligrams twice a day, whether they've got 2 out of 3 of those dosing criteria or whether they've got creatinine clearance below 30, it doesn't matter. If they then have an acute PE and they require treatment dose for that, they will go up to 5 milligrams twice a day, regardless of their renal function. I say that if it's below 15, they'll be on warfarin, but we'll forget about those at the moment. If they are eligible for a DOAC, they will go on to that higher dose of apixaban, regardless of what their AF dose would be. If they then need to stay on long-term prevention for an unprovoked clot, then their dose will go back down to 2.5 milligrams twice a day, because that would be the appropriate dose for both their AF and their long-term prevention. Rivaroxaban, slightly different again. We have the 2 doses there for stroke prevention, as you'd be familiar with. With the VTE treatment, that's easy enough, that's once a day, so they would be on once a day, 20 milligrams once a day, regardless of their renal function. As with the apixaban, we would pick the higher dose. If they then need long-term prevention, ordinarily the long-term prevention of rivaroxaban is 10 milligrams. It's one of the indications we do use that lower dose for. That is only if they're not a high-risk clot, and that's a hematology decision whether they're high risk, low risk. So we do sometimes still use 20 milligrams for long-term prevention, but most of what you will see will be 10. If that is the case, if they need long-term prevention, if they've also got AF, they would then go back on, they would remain on that higher dose, 20 milligrams if they've got a creatinine clearance above 50, or 15 if it's below 50. Edoxaban and dabigatran, very nicely, are straightforward with their dosing. For if you've got dual indications, the dosing is the same, regardless of whether it's AF, acute VTE, or prophylactic VTE. The problem with those is, and why we don't often see them, particularly with the acute VTEs, is they need 5 to 7 days of dolteparin prior to starting the oral. So we tend to see the apixaban and rivaroxaban, and I'm sure that there's going to be questions around those. We'll try to put a slide together to have it make sense, but it is a complicated area, and we were always happy to try and, if people are struggling with it, to try and advise on the dosing there. Thanks, Janice. So I've got some slides here of interactions. I'm not going to go through these in details. They're really there for your information to refer back to. It's actually something up there. Most of them don't affect doses. Where they do affect doses, I have listed them. It was really a slide I have from another presentation I've given that I thought you might actually find, you might just find useful for reference. Whilst on this slide, though, I will just bring up, we've had 1 or 2 queries, actually one today, recently, about diltiazem and DOACs. We don't change away from DOACs with diltiazem. We carry on prescribing it. We are aware there is a theoretical interaction, but it's not deemed to be clinically significant. So with cardiology, we agree with cardiology, we will continue to prescribe a DOAC if a patient's on diltiazem. The only reason I've picked that out is because it has just come up a couple of times recently. Thank you, Janice. And then this is in a continuation of the interactions here. Thank you. So first of all, I've just got a couple of case studies. They're not complex. They are really just to demonstrate how we might sort of consider dosing a patient like this. So if we've got an 86-year-old male, he's had a recent TIA, likely caused by AF. It's a new AF, so he's not been on anything for it before. A fairly simple past medical history, some hypertension and dyslipidemia. I've given you the numbers there. His serum creatinine is 80. His creatinine clearance is 49, and he's got a weight of 60 kilos. His medication, he's not on a huge amount. He's got aspirin, which he was put on when he had the TIA, the 300 milligrams daily. That's going to stop, and he's to start a DOAC. So what I want to go through is which one and which dose. So Janice has got a thing got a poll that she'll put up. Take a look at what do you think his CHA2DS2-VASc score is?
I am gonna not really use Mentimeter 4, so apologies if it doesn't work. So if you scan the QR code on there, that should take you to that. Equally, let me just bring this across. And the details should be on there. So I think the first question was, what was the CHA2DS2-VASc score, wasn't it, Kirsty?
Yes.
It is working, Janice. I've just done it.
Thank you.
So, because I can't see it. So.
IT skills. Okay. So, oh, right, we've got our first ones. People are thinking. So we had 6 responses. We can wait a bit longer, Kirsty, or we can.
The time's ticking. It's just to really to give us something to discuss around.
So ready whenever you are. If you want to.
Yeah. No, we can carry on. So we're favouring 4. So we would give him 2 for his age. He was 86. I can't see the screen now. I should remember. Sorry. There we go. He's 86, so we've given him 2 for his age. He's got some hypertension, so we're also giving him a point for that, which is 3, and we will also give him 2 for his TIA. So those of you who put 5, that's what we would think it was. That's how we would mark him for his CHA2DS2-VASc. Sometimes the CHA2DS2-VASc, when sometimes around the vascular stuff, and can be a little bit up for discussion, but it certainly gives us a guide of his stroke risk. So he's relatively high risk of a stroke. The next question we had, have you got that one, Janice?
Yes. So
which DOAC, and there's not necessarily, there's some answers that are better than others here, but there's not an out and out right answer. He is based around a real case, so I can tell you what we did do, but bearing in mind the parameters that we had there, what would you think about starting him on, and what dose would you pick?
Might need to remind people. Sorry, I haven't put.
Yeah. So he was 86.
Yeah.
He was 60 kilos. He had a creatinine clearance of 49. His serum creatinine was 80. I don't have a trend for his serum creatinine, but from recollection, it was fairly steady.
People liking Apixaban 5 BD as the top runner.
Yep. So when we actually reviewed this gentleman, so those numbers were fairly accurate to what we actually had. We did go for the 5, and we did actually ask him to go and weigh himself, because we wanted to see whether he was actually less than 6, just under or just over 60. And he came back, he said, no, I am exactly 60 kilos. So because the CHA2DS2-VASc score was on the high side, and his renal function was good, it was stable, we went for the higher dose of Apixaban. There are some circumstances we might have picked the 2.5. But interestingly, nobody picked anything else on there. We did stick, we were onto a loser around the borderline of creatinine clearance with the rivaroxaban and edoxaban. So we stuck with the Apixaban. We went cost effective, but we did go for the higher dose, although he was 60. We also wrote in our letter, should he lose significant amounts of weight, should he sort of decrease in weight and remain at a reduced weight of under 60, then in time he might be for a dose reduction. He might have put weight on, at which point he would remain at the 5 milligram dose. So he was one that we did have around the borderlines. If we have that coming through the DOAC clinic, I do try and train the rest of the team to do the same, but certainly as a prescriber and as a clinician there, when I'm writing a letter to go out into primary care, I will try and put the reasons for my decision as to particularly around the borderlines. You know, we've decided because of the high CHA2DS2-VASc that he should have a dose of 5 milligrams, but if his weight should persistently drop below 60, it may need to be reviewed. So we will try and put that guidance in there.
So in terms of, I guess, practicality, so actually, if it's, we obviously do get it initiated in primary care. So if you've got patients on that kind of borderline where it's kind of weight or the renal function, what do you tend to kind of look at? I guess that the kind of practical tips.
I'd look at the CHA2DS2-VASc. So if you've got somebody who's relatively low risk, it's perhaps, particularly if you think they're a higher risk of bleeding, so you might look at one of the bleeding risk scores as well. We haven't covered that today, and I'm not going to start that now. But at the end of the day, we're trying to prevent strokes from happening. With this gentleman, the creatinine clearance is 49. His renal function is actually quite good. It's just he happens to be on the borderline of weight, and he's an older gentleman. So. And the whole trend was steady. If the trend isn't steady, if we've got, you know, a serum creatinine that's going way up and then way down, we might easily pick the lower dose, because we do get to a point where actually the renal function is actually going to be a bit more influential in it. But we will look at just how much of a risk of stroke that patient is. And, you know, we can, if we find that we're on the borderline and somebody has a higher dose and they get bleeding related side effects in particular, then actually maybe at that point it would be sensible to reduce the dose. We would encourage people, if there's a real problem like that, maybe refer them into us as a clinic and we can take a look at a bigger picture. We've got all their hospital notes at our fingertips as well. We can maybe get a bigger picture of what's going on.
And there's quite, I don't think we'll get to the second case study, so just wanted to pick up on some of the other bits that have come through questions. So I guess touching on weight, we've got, there were a couple, that was the, what do you do over 120? And then what do you use to calculate the creatinine clearance? Because EMIS have got a calculator, but there's like MD Calc, and obviously you've got adjusted weight, actual weight. Yeah, and obviously when you calculate, depending on what weight you use, actual or adjusted, there's then discrepancies. So any advice on that, Kirsty?
So we use actual body weight. We used to use adjusted body weight, but the general rule is we use actual body weight now. That's the advice we've been given and we follow that. Up to a point, once you're getting over 120 kilos, it is obviously going to skew your creatinine clearance. I think we probably tend to look at the trends of the creatinine for, you know, once we get to the over 120 kilo patients. And if you've got a 6'4", 6'6" bulky gentleman, actually 120 kilos isn't a crazy weight for them, you know. So at that point we would use actual body weight. So we do take some other factors into consideration, and most of the time it's actual body weight we use. What was the other bit you asked?
Calculating renal function.
Please don't laugh. I use a pen and paper and and a calculator. We use the Cockcroft and Galt equation. We don't tend, for men, we put in the we do put in the factor of 1.2. There's a, I can't remember what the factor is. It's like a constant factor that you put in. For women, it's so close to 1, we don't actually put it in. So because it's an estimation, and it is an estimation, it's an estimation of where the trend is going. We don't do all those little bits, so our numbers might come up a little bit different. There's one of the systems, I don't know whether it still does, often comes up with a very different answer to what we come up with.
I think that was EMIS, actually.
I think it was EMIS.
I think most places, like if they're using an online calculator, tend to use the MD Calc one.
And I think we do have one or two across the trust that use the MD Calc. It gives a similar answer. If you're 1 or 2 mils different to us, it's not the end of the world. We did go through a spate where there was sort of 10 mils per minute difference, and that obviously, sometimes we're getting referrals saying, well, it's this low, and actually when we're looking at it, it's not. And I think that was the problem we had with EMIS. I think that was.
I do think it's been corrected though. I'll need to have a look at that. It was a while ago where I think we noticed that it was a bigger discrepancy. So I'll follow that up and just double check. But I know that it was the EMIS one, which.
But we do tend in the clinic. We do tend to manually calculate it.
But it was looking at the trends, wasn't it, Kirsty?
Yeah.
Not just the static.
Yeah.
That you're looking at. So actually, have you looked? You're looking at the trend of the creatinine. And actually, if there's a difference, have you calculated where it was then, and then it's taking that approach rather than a static one, wasn't it?
Yeah, and I mean the other thing that we see in secondary care is we get patients come in with acute AKI, and that obviously affects the dosing, and they get changed while they're here, and then they get changed back again when they go out, because after sort of 3 or 4 days, it's all sort of sorting itself out. So, what do you do with those patients? Do you change the dose or don't you change the dose? I think you've got to just have a look at the ongoing picture.
There was a question on hemoglobin and platelets. If they drop, is there a particular threshold where you'd kind of be worried, or where they should be kind of referring in?
So I don't think the haematologist would take many referrals for platelets above about 50. If there's a significant drop occurring and you think it's related to the anticoagulation, if it's only been since anticoagulation has started, and particularly if the hemoglobin's dropped, then it needs investigating. We tend to look anything below 100 as being low, but we do go lower and still keep them going. We don't do the investigation, so I don't know what sort of levels the haematologist would accept a referral for. They probably have to be looked at again as a general trend. When's it started dropping? Has it started before the anticoagulation started or after the anticoagulation started? It can obviously be a sign of bleeding somewhere. So it shouldn't be totally ignored. The platelets we do go quite low with them, but we would refer at about 50 to 70 would be based on the ICE parameters that we go with.
I think it's just the kind of considering all the factors, isn't it?
Yeah.
Like what their stroke risk is, the bleeding risk, and usually most cases bleeding the stroke risk kind of outweighs that, doesn't it?
And I mean we should have, if you've got a patient on a DOAC, you should have baseline bloods from when they started, and obviously a patient can change clinically, that's over time, but that's why we say within the last 6 months, so that we have something relatively recent we can compare it to if things then start to go wrong.
I'm going to just continue going on through some of the questions because there's still quite a few people on. So if the patient's on, say, aspirin 75 milligram once a day for CHD and they need DOAC, would we automatically stop the aspirin?
Usually, yes. You will get some of that protection from the DOAC, and if you keep the aspirin going, you're increasing the risk of side effects. When I would say no is if they have had a stent within the past year. So as a rule, we will keep it going alongside a DOAC if a patient has had any kind of cardiac stent within the past 12 months. But we also, there are some patients that are just so complex from a cardiology perspective. If it's just simply a bit of CHD, then that's fine, we could stop it. But We've had one today that's had multiple stents and was on warfarin and aspirin, and warfarin and clopidogrel actually. And it's like, do we keep the clopidogrel going when we put the DOAC on or not? They've been under Harefield. They've had multiple cardioversions that have failed. They've had all sorts. And actually, we think that's a cardiologist's decision as to whether that clopidogrel stops or not. So although the stents in that particular patient are over 12 months old, they were done in 2018, but there's multiple ones. We're just a little bit nervous to just stop it. So most of the time, yeah, but if there's a complex cardiological background, I would be inclined to sort of seek further advice on it. But ultimately, you're increasing the risk of bleeding. So if you can stop it, then it should be stopped.
So then in terms of if a patient's, so request to continue DOAC in a patient who has had a stroke, clopidogrel also added, when do you then continue prevention? What happens when a patient's had a stroke?
Are we talking a stroke on a DOAC?
Yes, from what I understand, yes.
Probably. Often clopidogrel is added in for a month, 6 weeks, and then stopped. That tends to be the decision of the stroke team. I don't think they see any long-term benefit of holding the two together. We have had very occasional patients that have been on both, but not very often. And those tend to be patients that have had a stroke on about 3 different DOACs and a stroke on warfarin. So, you know, the antiplatelets then added out of sheer desperation, really, is what else can we do? But most of the time, you wouldn't keep the two going together long term, but it would be a stroke consultant decision. Yeah,
so I guess if there's any kind of questions around that when there's that transfer of care, but it's not clear, then it's important to go back to the specialist team, isn't it, to really clarify, because actually we have had quite a few kind of incident reports actually around DOAC. So there seems to be a theme of either it was continued when it shouldn't have and they had a hemorrhagic stroke, or they should have been continued because they had a cancer associated thrombus, so they were on a DOAC, but then it wasn't continued once they'd gone out into primary care, and it's that transfer of care, that communication. So if in doubt, it's kind of best to check and get back in touch with the team. So there are quite a few questions around. I think, like, it's quite a complex. The dosing is quite complex to get your head around, and
yeah,
it took me like months, ages to get around as well. There's more kind of information on the slides here. I don't know if there is anything.
So yeah, this wasn't so much as dosing. This was just some generic sort of information, a comparison of them. Again, some slides I've had from before, which I thought might just be useful. I think the one that you've just flicked past has sort of got, your route. It's not about dosing, but it does tell you which ones you can give down a NG tube, or you can crush or not crush, which may or may not be relevant. And
I think, well, apixaban is the one that confuses people the most in terms of, if they're 60 kilos, which way do you go? Do you go 5 or do you go 2.5?
Yeah.
So if they're 59 and they're over 80, then that's 2.5, isn't it, Kirsty?
Yes.
They're dead on 60, then it's dead on 60.
Well, I think technically, I think the SPC says if they're under 60, but you are then sitting on the borderline. Yeah.
Yeah, so it's looking at a trend, because, like you say, it's kind of changes. We are working on updating the guidelines at the moment across the 3 and making it kind of bob wide. So we will try and make that as kind of clear as possible.
I think you mentioned earlier about body weight.
Yes.
Patients over 120. So at the moment in Bucks, and I don't think it's the same across the whole patch, but in Buckinghamshire, we will prescribe over 120. We will monitor we will carry out a one-off DOAC level. We won't really prescribe over 150. So we've got information up to 150, but we will monitor a level between 120 and 150 kilos. It is different for VTE. So if your patient is on a DOAC for VTE, they don't have an upper body weight. They say, I haven't had an answer when I've asked, what do you do with a patient over 200 kilos? I don't have an answer to that because I'm not comfortable with that. And I haven't had a consultant answer on it. But the VTEs, they don't do any levels, and there is evidence that says that they don't need to. From a cardiology perspective, certainly within bucks, they're far more cautious than that. So they ask us to do a level to make sure they're therapeutic before cardioversion or, you know, for stroke prevention. So we do the 120 to 150. And we prefer rivaroxaban for that because there's a little bit more information out there about rivaroxaban than apixaban, but we do see both. And we won't do it for edoxaban because we can't do an edoxaban level in bucks.
And I think the levels and kind of matching up to clinical, clinical importance or how it translates is still, not very clear. So it's definitely quite a bit more of the specialist.
I mean, we advise any patients over 120 kilos, they should be referred into secondary care for dosing and checking. And the level has to be done within either Wickham Hospital or Stoke Mandeville Hospital. It can't be done at Amersham, and it can't be done in primary care because it's time critical in getting it to the lab. And I
don't think the other areas as in Oxford and Berkshire-West actually,
I don't think
really look at levels at all. So it's not so it's definitely not something that's done across the whole of Bob. Someone said the BNF actually says 61 kilos, but not 60 kilos as the cutoff for apixaban. I don't think I've ever noticed that, but
I don't think I've ever looked at it in the BNF. I'm usually on SPCs or guidelines or trials. So
we're over time, but there's one last question I want to just get whilst working on. It was around the monitoring. So when we're doing the ongoing monitoring, is it just the UNEs that we need to do, or should we be doing the FBC, like LFTs as well?
You should be doing the FBC and the LFTs as well. So certainly the anti-10As can cause derangement of LFTs. So, if they do, particularly a rise in ALT, so if they do cause a rise in ALT, then it's possible, if it's high enough, that the DOAC actually needs to be stopped. So until the LFTs normalize and then re-challenge with a different one. And then the FBC needs done to, we've had the question about the hemoglobin and things. Well, that would be a sign of anemia, maybe related to GI bleeding, for wanting an example or something. So yeah, they should have those done as well.
I think we've covered the majority. I think there's still so apparently SPS also says 61 kilos, but the SPC says 60, doesn't it, Kirsty?
I think so, yeah. I mean, ultimately, whether it says 60, 61, whether it's sort of 61 and over or 60 and under, there's a borderline somewhere. So patients aren't that kind in sort of staying away from these boundaries that we have. It's not always cut and dry. So, unfortunately, wherever you have a boundary, there will be somebody that sits on it, and you've got to make that clinical decision.
Well, and depending when you measure your weight as well, it can change day to day or even time of day.
whether you do it after Christmas or just before you go on holiday.
Okay, I'm just going to cover Paula's one. People are having to drop off. So they've got a patient under NHH. I don't know where NHH is. With an ALT of 600 and a DOAC not stopped. Should we be asking the hospital to review?
Yes.
Oh, Basingstoke. Okay, that's part of Frimley then, isn't it?
We contraindicate all DOACs at more than 3 times the upper limit of normal. The upper limit of normal of the ALT for bucks is 105. And we tell our hospital doctors, our hospital juniors, it's 100 because that's just a nice round number for them to remember, but it's actually 105. If it was on the way down from something like 600 and it had reached 110 and was sort of climbing down rapidly, we might say, yeah, that's fine. but at 600 we'd be very twitchy.
Yeah, so Paul was saying they've stopped all of the medication. I think it's worth just asking.
Yeah, it could even be the apixaban's causing it. It's possible.
I think we've covered the majority of questions. I think there are a lot of things of, maybe it's something we need to take away to try and make it a bit clearer or more understandable, because it can be quite confusing with the different DOACs and doses and where there are those borderlines. But I think it's kind of being pragmatic, because your weight can change from day to day, so it's quite hard then to stick to the where do you go. And I know what we've done before, like Kirsty said, in the clinic, if someone's in the borderline, can you use another one where they don't straddle that that dose? And I certainly know for the Bucks clinic, obviously it's always discussed with the patient, because actually if they can't remember to take a twice the day one, there's no, they're at bigger risk, aren't they, Kirsty?
Yeah.
So it should be a patient shared decision making, and equally, for the rivaroxaban, if they can't take it with food, if they don't, take their tablets with food, or they can't remember to, then actually that absorption is going to be much reduced. So are they better on another one? So there's lots of things to consider, but we are working on the Bob guidelines, so, and to try and put that all together. So hopefully that might take us a little bit of time, but we are working on that. But so I don't think there's any other questions that I don't think we've covered in some way, but I will take them away and I'll pop them onto a kind of document, and I'll go through, Kirsty, with you.
Yeah,
and we'll put that together, and we'll put it on SharePoint when that's up as well. That might take us a few more days, but the slides and the recording of the webinar will be up on SharePoint after this.
And I have to confess, as I started to explain that dual indication, I realised just how complicated it is, because I deal with it every day. It's part of, it's my job, and trying to actually explain it, I think this is really confusing. So yeah, we're always happy to try and help. Don't always know the answer, but
yeah. Thank you very much, Kirsty. We'll bring it to a close there.
Thank you.